Hi, today we're going to go ahead and discuss well woman visits, and we're going to specifically discuss adolescent visits and middle-aged visits, and then also geriatric visits. So first, let's talk about some tools in your shed. The first one I want you to think about is we're going to talk about women's health. I want you to actually utilize who are stakeholders. So who sets the golden standard? For example, when I'm reading a case study and they talk about pap smears, I don't like to see the Family Medical Guide referenced. I want to see the ASCCP guidelines referenced. So all of these tools are actually apps you can utilize. So the ACOG is American College of Gynecologists. They have an app. That app on it will have opinion papers that you can read. That would be the golden standard. They set the standard of care during for obstetric care in the United States and also for women's health care. The ASCCP is another app. This app is it's like $9.99. So you can also go to the website. And in a minute, I'm going to click out of this PowerPoint and show you what the website looks like. But for $9.99, you get this very easy to use app where you can put in a woman's age, her last pap results, and her sexual activity, and it will tell you what your next test is to order, whether you're going to do like a pap smear or a pap with HPV or go to colposcopy. So when you're interpreting pap results, you are really going to like the ASCCP app. You can utilize this app without, you can't find this information just on the website also, which is always fine to look up things. The next thing to look at is the EPSS. So this is actually the United States Preventative Task Force. They're the recommendations that have, it's another standard. If you think about the United States Preventative Task Force, one of the things they are tasked with is actually to bring down healthcare dollars. So sometimes you're going to decide to go with their recommendations, and other times you might decide not to. Hippocrates medical references, and then I want you to also get an OB wheel because you're in women's health now. So anytime you have someone's last menstrual period or estimated date of conception, I want you to be able to calculate how far they are along in pregnancy. So right now, pause my lecture, get out your iPhone, and get these type of apps. If you have an Android, you can also find these on the Android. So let's set your cell phone up for clinicals. Okay, right here is the ASCCP, and this is going to be your standard of care for pap smears, colposcopies, and even anal cancer screenings. So if you go to the website, which you can find on www.ascp.org/guidelines, I'm going to hit up here to clinical practice. You can move this so you can see it, and it has guidelines. I'm going to click on guidelines. You can also buy a hard copy of these guidelines too. I am definitely from the generation of the internet, but some people like a hard copy. And so this is a website where you could order a hard copy if you want to have that in clinic with you. So management guidelines and screening guidelines. So right here, we're going to go to the screening guidelines. And this also has the United States Preventative Task Force, the American Cancer Society guidelines. All right, so if you go to the bottom of the page, to the bottom of the right, you're going to see a little green symbol that says guidelines. I'm going to click on that. And then that will bring you to your screening guidelines. I'm going to select this. So here you can go ahead and download the 2019 ASCCP Risk-Based Management Consensus. And if you go through this article, it's going to give you the reasons, but it also has algorithms. So for example, this is an algorithm for a patient who has an unsatisfactory cytology result. So that's going to be a pap smear that doesn't get those cells from the squamous junction that are kind of where they transition from the squamous cells to the columnar cells. So that's your more likely area to get cancer, is actually where they're transitioning. So you can go to it and they will say no HPV, unknown result, any age. You're going to follow that up by an age-based screening after 2 to 4 months because you actually have to give it a little bit of time. You can't repeat the pap right away. So you've now got if I have an 18-year-old, well, if I have a 21-year-old girl and her pap came back unsatisfactory and she had no HPV, I would repeat her PAP in 4 months. And then I'd manage it per the rest of the guidelines. If she was HPV negative, same things. HPV positive, I could either repeat the PAP in 4 months or go to colposcopy. And this is going to be with someone who is greater than 25 years, where you're going to have the choice. If someone is HPV 16 or 18 positive, you're going to go to colposcopy. So if you go through this article, it's actually going to list all the different scenarios that you will have as a clinician. And then I also posted on our website these standards for you guys to review. So go ahead and review them. And then the app that I showed you earlier actually makes it so you don't have to go through all these algorithms, where you can just plug and check. So basically plug in the age, plug in the patient's last PAP result, and they will tell you what to do. And that is, I think, for $9.99, probably worth your time and investment. Okay, so when you are seeing a well woman's visit with someone who's an adolescent, much of your well woman visits are going to be anticipatory guidance. You can use the Tanner scale to note where they are in their development and give them guidance for the next phase. For example, puberty generally starts between the ages of 8 and 16. The earliest signs are breast buds, which are usually like a nickel-sized bumps under the nipple. Breast buds are followed by pubic hair, physical growth spurt, and finally menstruation and hips widen. Sweat glands get larger also and more active. So teenagers sweat more overall, and typically this mixes with bacteria, may cause an odor. Soap and water followed with some antiperspirant can usually solve this. So if you are looking at a patient who's in, Tanner stage 1, you might kind of give them some guidance that they might anticipate having some growth of those breast buds and some hair in different places, followed by some different changes in smell. And you can kind of help them have some anticipation for what the next stage would be. This would also be good to know these stages when it comes to seeing if someone has precocious puberty, right? If you are looking at an 8-year-old who's further along on the Tanner scale than you would have anticipated, or if you were looking at a grown woman who's having primary amenorrhea and she's not developed on the Tanner scale, that might let you know that part of the reason she's not having a menstrual cycle might be some type of delay in her puberty. So this is an important scale to know that you're going to do on a physical exam. So whenever I think about teenagers, especially adolescent patients I see in office, I think about their brain development. This is really key in understanding the counseling and anticipatory guidance you're going to give them. During adolescence, the brain begins its final stages of maturation. There are 2 primary brain functions that develop at different rates. The limbic system, the part of the brain that perceives rewards from risks, begins rapid development. The reward center does not stimulate the risk that they once took as children, so they require kind of greater risk. So if you think about this, the fastest developing area of a teenager's brain is their reward system. This is partially kind of why you're going to see some riskier behavior during adolescence. The frontal portion of the brain is also not fully developed. View this as your brakes. This leaves teenagers from relying on the emotional centers of their brain to make decisions, minus the executive function. The prefrontal cortex, or the frontal lobe, which governs your executive functions of reasoning, advanced thought, and impulse control, is the final area of the brain to mature. This does not actually mature fully until later adolescence and young adulthood, usually around 24. Girls usually develop this sooner than boys. Oftentimes, when you think of someone with ADHD, as they develop the frontal executive function part of their brain, they will actually have usually an improvement in their ADHD symptoms as they are having improved impulse control. So let's talk a little bit about this teenage brain. We have our greatest area of growth is in reward seeking, and we are missing our break. So honestly, it makes sense to me that we've got this pleasure seeking brain. There's no breaks. So it's kind of easy to see how unplanned pregnancy takes place. Teenagers typically do not perceive the risk. They don't perceive the risk of unprotected sex while they are seeking pleasure. Oftentimes when I discuss this with a teenager, they'll come in and tell me that they've been having unprotected intercourse, and I'll ask them, do you think there's a possibility of pregnancy? And oftentimes their answer is no, of course not. Like, that wouldn't happen to me. And so it's definitely something in their brains that they can't perceive. And they also think that just happens to other people, doesn't happen to them. This can also be applied to other risky behavior I want you to think about, like drinking drugs, vaping, pleasure-seeking, smoking, marijuana. When you are doing a teen visit, it's important to address these areas. With teenagers, I'm very specific. Do you drink? Do you smoke cigarettes, smoke pot, or do other drugs? One of my favorite tricks is to go ahead and listen to their lungs and then ask them the smoking questions. I find a lot of teenagers tell me more about their smoking when they think I can hear it in their lungs. When it comes to sexual behaviors, I ask teens very specifically, do you participate in penetrative intercourse or penetrative sex without birth control? This question I'm going to ask regardless of gender expression or sexual orientation. Just because someone might self-identify as a lesbian does not mean they are not having heterosexual intercourse. So it is important to really identify their risk for pregnancy and address this during their visits. Finally, teenagers should be evaluated for depression. Due to their impulsive nature, they have elevated risk for suicide and cutting. If I'm starting a patient on an SSRI on this population, you need to be extremely careful for risks of suicidal ideation. They are higher at risk when you start someone on an antidepressant to actually see a risk of increased suicide. When I would start a patient at this age group on an antidepressant, I need to have some good follow-up. I'm going to do a PHQ-9 or PHQ-2 for them. I'm wanting their parents involved or some good caretaker that can also be watching them at home. I'm going to need follow-up every 2 weeks at least the first time, and then at least 6 weeks after that, because this patient is at an increased risk as they're feeling better to actually go ahead and act on some of those suicidal ideations that they have had in the past. And then finally, I'm going to check up if they have a firearm at home. When you think about teenagers and suicide, it is actually a higher percentage with male patients than female patients, and you're typically looking at firearms. So this is something when you're thinking of ordering an antidepressant that you really need to think about. And just going back to where their brains are at, if you're impulsive and your executive brain is off function and you're in this moment where everything just feels so intense and things are hard, it makes sense to me why something like a gun could be very much dangerous for a teenager in their home, because if they're impulsive, that's a moment they can't take back. Over COVID, mental health has been definitely a side of COVID when it comes to our adolescent population that has taken a huge hit, as teenagers have been isolated from their friends, isolated from school, isolated from some of their support structures. We're seeing higher rates of suicide in the pediatric hospitals, higher rates of suicides in the mental hospitals for teenagers. And to be honest, the hardest combination is your medical site. There's not many hospitals that actually specifically specialize in both. So placing these teenagers within our healthcare system is also a challenge. So COVID has brought many challenges. In my view, it's kind of shown us the cracks of our healthcare system. All right, let's talk about PAPs. In the teenage population, you do not need to do a PAP, regardless of sexual activity. Hold your hand up now and say, I will not PAP teenage girls because they are sexually active. When you are doing a screening test, a PAP that is just done for age group, you do not do this under 21. There are times that you're going to do a PAP smear as a diagnostic test. So the difference is, if I'm PAPing a girl because she's 18 years old and she told me she's had 2 sexual partners and I think, ooh, that sounds risky, this isn't appropriate. But if I'm PAPing someone because I'm doing a vaginal exam and she came in for bleeding post-coitus, right? And on her cervix, I can see a lesion, or that junction area of the cervix doesn't look normal to me, or something concerning, and I choose to PAP. This is no longer a screening. A screening is something we just do to everybody based off of an age and a recommendation. But when I do the PAP because I'm seeing concerning cells, this is now more diagnostic. And so you can PAP under 21 if you see something on exam. Otherwise, do not do it. And if you think about it, let's talk a little bit about girls under 21. Honestly, if you look at the research, it's 80% positive for HPV, but yet typically doesn't go to cancer. So part of the reason we're not PAPing this group under that age is it in the past was resulting in a lot of colposcopies. These girls would test positive for HPV, then have to go colpo. Remember, colpo is taking actual samples from the cells of the cervix. And then most of these girls, majority, over 98%, were non-cancerous. And so most of these girls would go through these kind of invasive procedures when it was not going to go to cancer. But another problem is the cervix actually has a job, and the job of the cervix is, it holds in pregnancy. It is the opening to the uterus, and it dilates during labor, and the baby comes out. One thing you can see as a provider who delivers babies is when that cervix scars from a LEEP procedure or from colposcopy or any medical procedure. Sometimes I've had patients where the cervix has thinned out but not been able to open, and on exam I can feel a fibrous tissue that's a scar tissue that's keeping this cervix from dilating. And you can also have the other problem where a cervix dilates too fast from having had a colposcopy or a LEEP. But in my clinical practice, I typically see the opposite, a scarred cervix. And it will be an interesting hand exam because the reality is the cervix will get so thin that I can feel the baby's hair through it. The baby keeps on coming down in station, yet the cervix stays at a 1. And this is the type of cervix that's a very atypical exam to the hand, but it's the type of cervix that just pops. The patient finally gets to be 2+ and your cervix will melt. So this is the type of patient that you don't send home at a 1 because you have to remember that they are in fact progressing the labor process, but having had a previous LEEP procedure or colposcopy procedure has resulted in fibrous tissue. And remember, scar tissue is not functional tissue, and the scar tissue has made it so the cervix is not as functional. So this is one of the reasons why we really don't want to just PAP girls under 21. There is a risk. To most tests you run in medicine, there's a risk versus a benefit. So when you are going to go ahead and PAP this age group, just because you're going to now get a positive HPV, and now you're going to have to definitely go to colposcopy. Don't gather that information. You're going to do some damage. Make sure that you're only gathering that information when you see atypical cells. And why would I do it then? Because then I know I'm in that 2% mark, right? I told you like about 98% is going to be nothing. Well, if I see something, I better go ahead and investigate. But otherwise, I'm going to leave it. Okay, breast lumps. We think a lot about with breast lumps mammograms, right? But that's not what you're going to order on a teenager. On a teenager, you're going to go ahead and order an ultrasound. And part of the reason why is young girls' breasts are very, very dense. And so mammograms are less accurate in a very dense breast. So you're going to go ahead and do a breast ultrasound. And then you are also going to, if you wanted to, if you had a mass, you can also aspirate it if it feels like a cyst to you. If you take a needle and aspirate a breast mass that you think is cystic and get fluid off of it, that needs to go to pathology. A good rule of thumb in medicine is if you take something off somebody's body, it goes to pathology, okay? We don't just cut things off. If you take a polyp off a cervix, it goes to pathology. You take some fluid out of a cyst, it goes to pathology. This is just a way that we can ensure we're doing appropriate cancer screenings. All right, so since we're just discussing breast mass a little bit, we will further on in the semester discuss it, but we're talking about the well woman's visit. I did want to just go over how to chart it because I do want you guys to be ready to do a well woman's visit in office, and if you come across an abnormal finding during a breast exam, know how to write this. So this slide references the documentation for breast mass. For example, in this picture, this X would be charted upper quadrant mass 2 centimeters from the areola border at 10 o'clock. Firm, movable, oval, shape 1 centimeter by 2 centimeters with regular borders, non-tender. Breast exams just start with the patient also in a sitting position. When you start your breast exam, please watch the video that is listed in this week with the Stanford video. When you start in the sitting position, you're going to have the patient move forward and back and arms overhead and down. What you're actually looking for is dimples or retractions in the skin, because we think a lot about breast cancer as breast mass, but there's cancers that also cause like a pulling. Or you could look at the orange depile, which is where you see that skin that looks like an orange pill. So I want you to, and also there's inflammatory cancers too, right? So when you're looking at these breast exams, you're looking for retractions. That orange pill type skin, inflammatory areas like a big red spot. You're looking at the actual skin, the contour of the breast, and the shape. So kind of give it a look. You're going to have the patients move arms up and down. One thing I've run into as a clinician is there's like a lot of providers who are actually not doing a visual breast exam where they have the patients move their arms up and down. They're just having them lie down. And this, I think, is really due to the fact that they don't want the patient to be uncomfortable. So when I'm doing this type of exam for a patient, I might be their first provider to actually ever do a visual exam prior to the physical exam. So I actually make sure I explain it to them. We all have scripts in medicine. So my script sounds something like, today I want to do a very thorough exam. One thing I can do to be more thorough is to actually do a visual exam. I can check for breast cancers that I can't feel with my hands, because some breast cancers I can see. They will cause like a retraction in your skin or a change in the breast shape. So I'd like to go ahead and do a visual exam. It's a great way to be more thorough today without actually causing a more invasive test. Does that sound like something we can do today? I'm always getting permission, by the way, when I'm doing exams with patients, especially when it's like a breast exam or a vaginal exam. Patients can also always say no. And if they do, I'm not going to bully them into it. I find most of the time, though, if I explain to them the purpose, why, and kind of what I'm looking for, they don't say no. But they say no, I would just chart patient denied visual exam, was okay with, bimanual exam. All right, so now that you've done a visual exam, you're going to have them lie down, put an arm overhead. Remember when you're doing a breast exam to make sure you get into that axillary, because that is also breast tissue. How you do the exam is not super important, whether it's the lawnmower or the spiral. The reality is you just should pick to do it the same way every time so that you're not missing an area. If you're switching between the lawnmower where you're going over in straight vertical lines to the spiral and going back and forth, I think you're more likely to miss a step. So for me, I do the same thing every time. I always start with the left axillary, go all the way straight to midline. I go supraclavicular, axillary, feeling for the, I'm going to feel for the axillary nodes. So I'm going to feel supraclavicular, axillary nodes. I go first down the neck, then over the clavicles, then in the armpits. Then I have the patient lie down, hand over head, and then I'm going to start with that tissue in the armpits and going, I like to do the lawnmower, to be honest, and I go all the way over and across. When it comes to the nipple, if you read the book, they always will talk about just squeezing it. That can be awkward in exam, but you still should probably put some pressure on it, because you are going to check, what you're checking for is actually breast discharge. I easily, when I'm doing a lawnmower formation, just keep pressing down and just press over the nipple with my hands as I keep going, versus doing the entire exam and then putting pressure on the nipple. That seems less comfortable for the patient. Okay. Now let's just talk a little bit more again about if you found a breast mass and you had a woman who was like 42, you're not going to actually order a mammogram that's diagnostic. If you didn't find a breast mass in someone who's 42, you'd probably order a screening mammogram. So prior to actually ordering your mammogram on a patient, you're going to do a breast exam so you know whether it should be a diagnostic or a screening. And the difference between the two is a screening mammogram is going to look at everything, and a diagnostic is going to look at your excellent documentation and look more deep into that area where you found the breast mass. So let's talk a little bit again about what we should be documenting. I want you to document location. Remember, the breast is going to be a clock, and then you have your quadrants. Location, and you're always going to do centimeters away from the areola border. So location, size, mass, shape, tenderness, margins, consistency, and mobility. And then it should include a narrative and a drawing. So if I'm seeing someone with an actual breast mass, I'm going to draw it. I'm going to put a narrative on that picture. And then I'm actually, my favorite thing to do, cut and paste on an EMR is great, is I like to take a snapshot of that documentation and put it on my actual order, because I think it is more helpful when I'm sending someone in for a diagnostic mammogram so that they can actually see exactly what I saw. Okay, so now you've ordered your mammogram, your diagnostic mammogram, or you've done an ultrasound because it's a younger adolescent patient. I find the age that you're really starting to do mammogram versus ultrasound is kind of around your 30s. You're going to move to the mammogram, and under 30s, you're going to typically be ultrasound. Sometimes between 30 and 35, I might order an ultrasound if I find it's more cystic. And if I'm wrong, usually the results will come back and say, we would like you to have a mammogram. I have found that usually radiologists are very good at guiding you as a clinician to know what tests you should be ordering if you are off base. So let's talk about the BI-RADS system. And the reason I want to discuss this is you're going to get results from these tests that you're ordering from your Well Women's Visit, and you need to understand what you're reading. So you've ordered this mammogram, your results have come into the inbox, and it says to it's BI-RADS 1, and you're like, woof, that sounds bad. Actually, not so bad. So BI-RADS 1 is negative. BI-RADS 2 is benign findings. BI-RADS 3 are probably benign findings. BI-RADS 4 is suspicious for an abnormality. And BI-RADS 5 is highly suggestive of malignancy. And BI-RADS 6 is a known cancer. And BI-RADS 0 means additional evaluation is needed. So when you think of the category 1, there's no follow-up. So when you ordered that mammogram for that breast mass you found, it came back BI-RADS 1 or category 1, you're fine. So no follow-up is necessary. Category 2 are benign findings. The radiologist may include part of the findings, such as it's a calcification, it's a fat-containing lesion, lymph node, etc. Category 3, it's going to be probably benign. So they usually on a category 3, 1 and 2 typically doesn't have a follow-up, but on category 3, it's going to have a initial short interval follow-up suggested by the radiologist. So this is on a category 3 and a BI-RADS 3, you're going to actually follow the radiologist's advice on your follow-up. These lesions usually carry less than 2% likelihood of malignancy. So they might say like in 6 months follow-up, and then if everything looks the same, they would discontinue the follow-up or maybe go to an annual follow-up depending on what recommendations the radiologist gives you. Category 4 BI-RADS is suspicious. Biopsy should be considered. You can further divide to 4A, which is low suspicion, 4B intermittent suspicion, 4C suspicion, moderate suspicion. Now, I want you to think about something. If you're in like a family practice clinical setting where you actually do not treat oncology patients or gyn-oncology patients or breast cancer, and you get a category 4, I would not biopsy this myself. I would want to actually have this go to a referral to the Huntsman Cancer Institute for me, because I live in Utah, but whatever your closest cancer institution is because if you think about cancer, actually biopsying can be tricky. Sometimes you can seed it, or sometimes you do not get all the margins. So now that I have a BI-RADS 4, that is something I'm going to take more serious and refer out, even as a women's health nurse practitioner, unless I'm a WHMP or FMP who has specialized in a clinic that specializes in cancer. And in that case, you would actually be co-managing this patient with a physician because of the level of risk. And then category 5 is highly suggestive of malignancy. This should be definitely referred out. And then these ones have a greater than 95% of probability of being malignant. And category 6, if it comes back BI-RADS 6, and I think in my entire clinical career, I've actually only had one come back BI-RADS 6. Usually, if it's pretty bad, it's still BI-RADS 5. But I've had one come back BI-RADS 6 that was just frankly cancer, and that again would be referred out. So hopefully this kind of gives you an idea when you get results back how to interpret it. And you can always refer back to this slide. Okay, let's talk about what I'm going to screen for in my adolescent population. First, we're going to go through the behaviors we already talked about. Suicidal ideation, drug use, drinking. How are they doing school? Are they going to school? Who are their friends? Do they have friends? Are they working a job? What are their grades like? Do they want to go to college? These are kind of some important things to know about this age group, actually. If they're sexually active, I'm going to screen for pregnancy every time. GCCT, this is site specific. One thing that I've noticed happens is someone will write, patient's primary form of sexual activity is oral sex, urine GCCT is negative. So that urine GCCT, if they have chlamydia or gonorrhea, it's most likely in their throat, okay? So testing their urine isn't going to catch it. So one of the reasons you're talking to teenagers about their exact sexual activity is not to make them feel uncomfortable or to guilt them. You're talking to them about that to actually do your tests in the right area. So my language for that, because I feel like as a provider, the more comfortable you get with having some of these hard conversations, and your language and your scripts, the better this is going to go for you. But my language sounds like this. Today, I want to do some screening. This screening, to be accurate, is dependent on your sexual activity. For example, if you're primarily having oral sex, then I need to swab your throat. But if you're primarily having vaginal sex, then I would want to swab your cervix. So I'm going to ask you some things about your sexual practices so I can best help you today. Do you feel comfortable with that? Letting them know. I find really informing your patient goes a long way. I'm going to let my patient know. I'm not asking these tests to make you uncomfortable, but I'm asking these questions about your sexual practice so I do the right screening. So GCCT, every teenager, every time, every year, right? I see a lot of chlamydia and gonorrhea. Sometimes I think we should just put azithromycin in the high school's water. Syphilis. This one is actually going to be for males who have male partners. And then if you have a female who has had a type of ulcer or something that looks suspicious of syphilis, then I would go ahead and run this test. But again, for screening, it would be men who sleep with men. But for a female where it's not screening, it's because I've seen something that I am concerned about, and that makes it more diagnostic. Mycoplasma genitalium. This is something interesting because I think it's kind of like not such a well-known STI, but definitely something when I've worked STI clinics that I run into. So mycoplasma is a type of bacteria that can cause an STD. You get it by having sex with someone else who has it. Symptoms are watery discharge from the penis, burning, stinking, or pain when the patient goes pee. So first thing I have to tell you, as a teenage boy with burning with urination, it is chlamydia in my mind until proven otherwise. This age group is really unlikely to get a UTI unless they have some physiological issues going on, like a retrograde ejaculation. So something actually wrong with their structure. Otherwise, this group, it's chlamydia. So say I have a guy who presents in clinic and he has like a clear runny discharge, and I test him and it's negative for chlamydia and gonorrhea. My next thought is it mycoplasma? And I would get the treatment for that off the CDC. Or my other thought is it trichomonas? With trick, if you think about it, these patients will often talk about a tingling sensation when they have an ejaculation, and mycoplasma has that kind of clear discharge that looks to me similarly as someone in practice as chlamydia does. One of the things to think of with mycoplasma is most labs do not actually test for on the routine. So this is going to be a diagnosis and treatment of exclusion. So this is going to be one where I did a GC-CT and it was negative. And then I'm going to go ahead and just treat them. And I might go ahead and treat them for mycoplasma and trichomonas. When you think about trichomonas, this one in females is going to present with like a pancake batter, strawberry cervix. If you're ever doing an exam on a patient and their cervix looks like a strawberry, you should right away think about trick. Trichomonas can be found on Pap smear results, and it can also be found on a wet mount, and it can also be found PCR. On wet mount, it has like a 40% miss rate. So whenever I see in someone's chart they've been chronically treated for BV, that might have been trichomonas. The treatment for bacterial vaginosis, the 7-day treatment, is actually also treatment for trichomonas. But the problem lies with the misdiagnosis is that you are not treating their partners. And in men, there's not an easy test for trick. So if you think about it, if I consistently have a female patient and I'm treating her for BV because I'm missing the trick, and even though it might treat the trick, she's going to consistently be reinfected by her sexual partner because I'm missing the diagnosis. And for her, when she takes the antibiotics because she's treating her trick, her symptoms will get better and then it will come back again. So she might think she has persistent bacterial vaginitis when in reality we are missing an STI. All right, now we've moved on from adolescence. I want to talk a little bit about a well visit for a woman. And I'm just going to read it out loud to you. So Sandra is a 28-year-old female who presents for a well woman visit. She's currently sexually active with a long-term partner times 5 years. She has been using the Depo for 2 years and is considering getting pregnant in the next year. Her last PAP was 1 of 2013, and it was normal. Sandra has never smoked and drinks socially. She denies any physical abuse or history of substance abuse. She's 5'8", 150 pounds, 128/72. And she is on Depo and multivitamins. By the way, anyone who is sexually active at a well woman's visit, regardless of being on birth control, should be on a prenatal vitamin. And this has to do with the folic acid that prevents neural tube defects is best taken prior to pregnancy. So once someone figures out they're pregnant, that's around 4 to 6 weeks, the neural tube is already formed. Prenatal vitamins help that neural tube form. So the way I view it is if you are somebody who is sexually active and you would keep that pregnancy, then you should be on a prenatal vitamin, because all birth control fails. I have seen every birth control fail. So if you are opening that gate whatsoever, I advise a prenatal. And then I kind of sell it to people with, stronger nails, better hair. Okay, let's talk about anticipatory guidance for this woman and what screenings are recommended. So remember your well visits that we're focusing on the adolescent population and in the young adult population and the elderly population. We're going to talk about anticipatory guidance for each of these people and their screening recommendations. And then you can always refer back to the stakeholders that I listed on the first slide. That's why it's the first slide of this lecture, is I want you to always be able to refer back to who I want you to reference for your screening guidelines. Okay, so if you look at the ASCCP, you're going to do a pap smear every 3 years. So she's going to get a pap. Once she hits 30, she is going to go ahead and get a pap plus an HPV, and we call this co-testing. And once you do co-testing, you can go every 5 years. Women get paps between ages 21 and 65. And between 21 and 30, they will be having a pap every 3 years. And between 30 and 65, they will have co-test every 5 years. The only changes in that will be if they have an atypical pap smear, and then you will follow the algorithms on the ASCCP website or on your iPhone. So that's going to change. Those are the screening guidelines, but if someone has an abnormal pap, they might have like an ASCUS pap and be 28 years old and have to have a pap the next following 2 years annually. So they will have to have 2 normal paps following up, depending on what the guideline is. So just keep note that these guidelines are the screening guidelines, and if someone has a abnormal pap, you are going to go ahead and follow the ASCCP guidelines that we visited on that website in the beginning of the class. Also remember that that app is another handy app, because you can just put in their last pap result, their age, current sexual behavior, and they will tell you what your pap would be. When I'm interpreting paps, I typically put a note on the chart. It makes it easier for the next person following me, especially if you're a busy clinic. I might write last pap this per ACCP guideline. Patient will have a repeat pap at 2019 and another repeat pap at 2020. Now remember, guidelines change. So one of the reasons I always put it in the chart is because if the guidelines change, but the patient had their abnormal pap during the old guideline, you actually are going to just follow the old guideline through. So that's another reason when I interpret a pap result and I put the future plan, that I'm going to put it in the chart. So the next provider who sees it can be like, oh, this was an abnormal pap in 2016. The plan was to repeat it in 2017, 2018. It's now March of 2018. I will go ahead and repeat it. This is going to help pap follow-up not kind of fall through the cracks, which is kind of an easy thing to have happen. We already talked about it. She should be on folic acid. Remember, all sexually active females need to be on a prenatal, and you're taking the prenatal for the folic acid. You're going to do blood pressure screening. On this patient in particular, and we're going to talk more about birth control, so if you didn't know this, I don't want you to feel anxious, but you need to consider changing her birth control. Patients who are considering conception within the year should be off of Depo, because it can take up to a year on a patient on Depo to actually get pregnant again. And then we should talk about helpful diet and physical activity at every visit, skin cancer prevention, behavior and counseling, and bimanual exams. These used to be, when I started clinical practice, we every visit just did like a bimanual exam. And like a bimanual exam would be where you're feeling for the reproductive structures with your actual hand. So people who entered women's health, kind of when I did, were good at our hand scales. We can feel where people's ovaries are, the size of their uterus, what direction it tilts. Anterior would be go towards your belly, and retroverted would be going towards your anus. And we can feel whether it's military, which is what you would think, straight ahead. Retroflexed, which is going to be just typically tilting towards the anus, and then antiflex, which is going to be towards the tummy, with anteverted and retroverted the most biased towards a direction. While you're in your learning phase, I would advise you to do your best to get as many bimanual exams as you can get in. It is a hand scale, and to be honest with you, to develop that hand scale just takes a lot of vaginal exams. When I think about a couple tips and tricks, like someone who is thin, I will take my hand and fill up, and if I can poke the uterus to my hand that's on top, there'll be a hand on top of the belly and a hand inside the vagina. And if I can feel the underside of the uterus and press it forward, that's definitely an anteverted uterus. And I can also feel the size between my 2 fingers. Then I will run the top finger to one side of the uterus to feel for an ovary, and then to the other side. If a patient has a larger BMI, or my exam is being interfered with her habitus, I'm going to reverse this. I will actually put pressure on the belly and feel from the hand inside the vagina, because the reality is I'm trying to get the shortest distance from these structures to my hands. So if someone has like a large belly, then I'm never going to feel her ovary on the top side, but I would feel it through her vagina. So that's just kind of some tips and tricks on bimanual exams. Why you're going to want to be good on a bimanual exam is you need to know the direction of a uterus if you are going to place an IUD. So it is a good thing to become good at, because when you're thinking of long-acting reversible contraceptions, you are going to increase your risk of perforating or putting your sound, which is this metal metal measuring device that lets you know how long a uterus is, you are going to increase your risk of misplacing the IUD or going through the uterus, which is called perforation, if you don't know the direction. So if you are thinking that the uterus goes towards the belly, which is anteverted, and it is actually going towards the anus, you could go straight through it. The good news is like 90% of uteruses are like anteverted. So for the most part, they are anteverted. And then there are some tips and tricks on IUDs we'll go on later on that can help you to straighten out the IUD if you feel like you are weak on your hand skills. So we definitely have some places we can go to help you with that skill set. Okay, we are looking at some slides. The first slide, the one to your left, is old school. This was the first slide that I ever worked with. So I'm taking the cells from that junction area, that is where it changes from the squamous cells to the columnar cells, where you have the increased risk of cancers, where these cells are transitioning. I'm going to take a sample, and I'm going to smear it on a slide, and I'm going to do 2 smears, and I'm going to spray it with setting spray and send it to the pathologist. The other solution is a thin prep, and what I'm going to do on this one is take a Cytotec brush, and I'm going to put it into the inner os, turn it a quarter, and then roll it and put it into the solution, which is that little jar contains a little solution. And then I'm going to take this broom. You can't see it in this picture, but that has like a purple stick, and it has like a white broom that literally looks like a broom. And I'm going to go 360 degrees in the cervix, and then I'm going to put it into that solution. And then I'm going to kind of try to shake all the cells off of both the Cytotec brush and the broom. So what this is going to give the pathologist is a solution that has a lot of cells in it. So when you think about getting an unsatisfactory pap smear result, you are more likely to get an unsat pap when you have the traditional pap smear. And the reason why is I'm taking a sample of cells and I'm giving it to the pathologist, and he's going to look for those specific cells. Otherwise, he's going to call unsatisfactory if he can't find those transitional cells. But on the thin prep pap, I'm giving him a solution with a ton of cells in it. So he's going to make a slide and look at it. And if he doesn't see the cells he wants to see, he's going to make another slide and look at it. And he's going to make another slide. And he has all the solution to make a lot of slides until he finds that cells he's looking at. So you are much more likely to get a good result with the thin prep. So why would anyone use a traditional pap over the thin prep? Cost. The thin prep costs much more than the slide. You are going to typically see the traditional slide on this pap in more community health clinics. When I do community health care, I find myself doing a lot more of these slides because it allows us to do more paps and give more cancer screenings to more women. Sometimes, though, just a caveat, it might be difficult to find a lab that can read these slides. For a period of time, I was working at a community health clinic, and our pathologist retired, and it took us a minute to actually find someone who could read traditional paps. And then finally, something I want you to think about is if a patient's on their period. I grew up with that. If you're on your period, you don't get a pap smear. That would be true for your traditional pap. If you get some bleeding on that slide that you're going to fix, it's very hard to see the cells afterwards, and it's definitely not going to result in something the pathologist can read. But when you have the thin prep pap, as long as it's not super heavy bleeding, I find that I'm able to usually get a satisfactory pap out of that. You don't want to wipe off the cervix because you're going to wipe off cells, but generally if the bleeding's light enough, it will not make it so the pathologist cannot read the pap. Okay, we're going to quickly actually discuss vaccinations that should be offered at your well women's visits. We're going to discuss the adolescent, middle adult, and then final geriatric patients. So vaccines that are recommended yearly are influenza. Hopefully COVID vaccine. If you're over 65, you definitely should have that available. And then hopefully everybody will have access to that. HPV vaccine is interesting. Currently, the recommendations by CDC is 9 to 26, and it's covered by insurance to 26. This is an interesting situation because kind of the thought behind this recommendation is you're going to have all of your exposure to HPV prior to 26, and after that you've been exposed, so there's no point to already vaccinating you. So if you haven't been vaccinated by 26, the vaccination will be a little worth because you would have already been exposed from a sexual partner. What I kind of do not like about this as a screening guideline is it's not really taking into account people's sexual behaviors. And maybe this is because I've practiced in Utah, but one thing I will see is sometimes women get married young, like 18, have one sexual partner, and then they get divorced at 40. And now I have a patient who is having a well woman's visit, going on birth control and re-entering the dating world, and has had only one sexual partner. Do I think she's had all of her HPV exposure by 26? No. For her, I would also still recommend the HPV vaccination, but part of the problem is that it's going to be out of her pocket. Sometimes you can find some of the community health centers will have allow someone to pay for a HPV vaccine at a discounted price. But I do think you should kind of dip into people's sexual behavior. Or if you had someone getting married at 30 who, for religious reasons, had abstained from sexual intercourse, that would be another person prior to their marriage that I think, if their partner had had other sexual partners, would be a good candidate for the HPV vaccine. All right. So then we've got the next one is meningococcal vaccine for college students and military recruits. Then we're going to go to the Tdip, right? Tetanus, diphtheria, and pertussis. You're going to get a booster every 10 years. Now, if a woman can't remember if she has had this, remember, oftentimes women will get this after having a baby in the hospital. So sometimes you can time and date her last Tdip based off of her last delivery. So pneumococcal vaccine, this one is going to be recommended for all kids younger than 5 and for adults with certain risk factors. And then all adults 65 and older. When we think about the risk factors for those who are going to get the pneumococcal vaccine, it's going to be those who are 19 and up with asthma, COPD, diabetes. So think about respiratory conditions. And then last, let's talk about immunizations to consider. One of them is the herpes zoster or shingles vaccine. This is recommended for people 60 and up. One question I get asked a lot in this age group is if they have already had shingles, if they should still get this. Yes, if you have had shingles, you most definitely should get this. This is going to lower the prevalence of actually having outbreaks of shingles. And if you've ever had shingles, they are pretty painful. So this patient, a patient who has a history of shingles, I most definitely want to go ahead and push this vaccine. Okay, let's talk more about screening. These screening guidelines listed above come from the United States Preventive Test Fast, the American Cancer Society, ACOG, and then also the American Heart Association for the blood pressure recommendations. So blood pressure should be taken annually, and if it's between like 120 and 80, it should be checked annually. If it's lower than that, it should be checked every 2 years. Do you remember when we talk about the American Heart Association, we should talk about some changes in blood pressure treatment. In the past, we didn't start treating people for blood pressures until 140 over 90, and now we treat 130 over 80. And if you remember, usually there's a 2-step approach to treating for high blood pressure. You usually start with one medication, but most people are going to indeed need 2 medications. There is an algorithm that you can find on the American Heart Association that will walk you through how to initiate someone on treatment for elevated blood pressures. Also, when you're going to initiate treatment, it's not going to be a one-time blood pressure. This is going to be across 2 separate occasions. And part of the reason for this is you have white coat syndrome. You would hate to start someone on blood pressure medications if they just came into office running late for their visit, drinking too much coffee, right? Let's make sure they really are having a trend that shows elevated pressures. Later on in the semester, we're going to talk about some conditions that affect women in particular with blood pressure. One of them is called preeclampsia during pregnancy, and then other hypertensive conditions like gestational hypertension. For the purposes of women's health and when it comes to pregnancy, we are not going to consider anything hypertensive until it's 140 over 90. ACOG has not adopted the American Heart Association's lower standard for blood pressures. So if you say a patient has gestational hypertension because they have 130 over 80, this is somebody who I think should be watched more closely, should have probably baseline preeclamptic labs drawn, but they do not meet criteria according to ACOG yet. Okay, cholesterol tests should be every 5 years for people who are not, for people who don't have increased risk factors. So you're going to do it more frequently in patients over 44, patients with diabetes, heart disease, kidney issues, and hyperlipidemia, and especially obesity, right? You're going to want to check that more often. Glucose testing is every 3 years, and you're going to start it in your 40s. Again, more frequent and earlier testing for those with higher risk, such as metabolic syndrome, obesity, high blood pressure. And then all women who have gone through menopause have a history of fractures should have a bone density test. When you think about who should be screened for osteoporosis with a DEXA scan, I want you to think about who looks kind of light, because the reality is smokers and women who are really thin and slight are more likely to have osteoporosis or osteopenia. Part of the reason you want to think about it is how our bones become dense. If someone is heavy, they're putting more pressure on the bones, and in the bone remodeling process, they're going to have denser bones. If someone has had a slight BMI, been 18 BMI their entire lives, and and isn't currently lifting weights, they're more likely to have osteoporosis. Again, this patient, if I'm looking at a patient in office and she seems very slight in figure and I know she's at increased risk for osteoporosis, this would be some of the anticipatory guidance I would offer. I would talk to her about maybe wearing weights and going on walks with those weights, making sure she has enough calcium intake and vitamin D, and kind of talk about ways to help her make sure that she is indeed getting bone remodeling and getting thick enough bones. Okay, and so women under the age of 65 who has risk factors for osteoporosis, and you're looking at a family history, that one should also be screened. Colorectal cancer screening begins at age 50 and every 10 years until the late 70s. And remember, the screening is every 10 years. You might have a patient who has a colonoscopy and it comes back saying that this patient should have theirs done every 5 years or every 3 years, or have it done next year if they found a polyp. So the reality is they're going to come back that test with recommendations. The recommendations may indeed just be every 10 years. And then again, if you're the person interpreting this lab and you get it back and it says every 5 years, get that scanned in the chart and put a note into it. It's important to document. Patient had colposcopy, findings overall benign. It is recommended patient have one in 5 years. 2025 will be their next colpo. Make sure there's some way that you are communicating with the many people that may be caring for this patient to make sure that nothing falls through the cracks when it comes to their screenings. Okay, and then finally, they always talk about anal fecal blood tests. Honestly, you can do this one every year. I do not find myself doing this unless patients really have complaints of blood in the stool, because this would be something where I might go ahead and refer them to a gastroenterologist if they're having bleeding that direction. Maybe they have a food allergy. Maybe if you think about it, they could just have a hemorrhoid or a fissure, but this is time to kind of check out why they're bleeding. And before we check out why they're bleeding, I'm going to use that test to make sure they actually are bleeding. There are some other causes that can sometimes cause redness in the stool. You can think about food dye, lava hot Cheetos, all those kind of things. Oh my gosh, let's talk about mammograms. These are the screening guidelines, by the way. These are not the diagnostic. There are 3 different opinions to what we should do. USPSTF discuss having a mammogram every 2 years between ages 50 and 74. ACOG says every 2 years between ages 40 and 49, every year after 50. American Cancer Society is every year after age 45. So what do I pick? Honestly, what I pick is really dependent upon family history and my exam. So if I do an exam on a patient and she has very fibrocystic breasts, if she has fibrocystic breasts, guys, and I'm not getting a really good exam, chances are I am actually missing something. Fibrocystic breasts have a much lower efficacy rate when it comes to having a bimanual exam that finds a lump, because that fibrous tissue keeps you from filling what you need to fill. So if I do an exam and she has fibrous breasts, I'm probably going to start her mammograms at age 40 and go with ACOG. Now, if I have a patient who has breasts that are very easy to examine, there's been no familial history of breast cancer, and she really doesn't want to get her pap smear, we're going to talk about risks and benefits, then I would be more comfortable with the USPSTF every 2 years after 50 to 74. If I have a patient who has a familial history of breast cancer, I do want to make sure I'm starting to mammogram prior to the age of her that relative's first initial breast cancer. So if the relative had cancer at like age 47, then I would definitely at the very minimum want to do the American Cancer Society screening at 45 plus. So the answer I have to give you when it comes to what screening am I going to use, it depends. It depends on my exam, her risk factors. Now, let's say that she has a family history who had a family member who had breast cancer very young. Then we also might want to see if we should be doing broncho testing, right? BR1 and BR2. And if she's positive for that, there's going to yet again be a different guideline for how often she should be mammogrammed. And this is going to be because, again, we're not doing screening at that point. We're doing this based off of genetic screenings that have told us that she has elevated risks of both ovarian cancer and breast cancer. So we will increase our surveillance on those patients to the recommendations from the geneticist. All right, finally, I want to talk about middle-aged women. I have been treating middle-aged women since I was in my 20s, and I will tell you this is my favorite age group. There is just something that happens when women's reproductive systems turn off. If you think about it, everybody goes through puberty. Everybody has this time and phase where their reproductive centers turn on. They become someone who can, make children, and things change and our hormonal balances change and we change. Men stay in this state, right? They can father children well into later age. They might have, maybe not as good as motile sperm, and they might sometimes have more genetic issues, but the reality is they are still reproductively turned on. But women, 10 years before 50, perimenopause is about 40 to 50, we enter this phase where we're actually turning down our reproductive system. And I have found something interesting happens. It is like we turn from outward and back inward. We've gone through this caretaking phase where we've made children. Some of us have been out of the workforce and spent this time developing our children. And this is a time period where I find women start to redevelop themselves and turn inward. I find people who have like a bad marriage, this is the time they get rid of that marriage. Women who had always wanted to go back to school. Women who want to have a business, go back to business. I call this the "you won't believe what I've done" visit. Because women in this age group oftentimes will say to me, "You won't believe what I've done." And it's because they are kind of reinventing themselves, and they're more likely than men are past the age of 50 to contribute to society. And this might just be because women are entering, due to duties with childcare, we're entering society later on, right? Like if you go back to school when you're 40 and then you hit 50, like you might now be doing your PhD paper. So really there might be some different patterns, and some of this might change with future generations as there's more women who might go through school in their younger years. We might see some of these kind of things I'm discussing today being different. Anticipatory guidance, I do think it's important when you're talking about women that we talk about perimenopause and we just tell them a little bit some anticipatory guidance. And the language I like to say to them is, this is a really exciting time period. You might find as you're reproductively turning off that you're turning inward, and it's a time of development. And I see many women have a renaissance during these time periods. This is one of my favorite time periods for women. They recreate themselves, and it's fun to watch as a clinician, and it's just a good time period overall. So yay for the 40s, right? Something to look forward to. Okay, so let's talk a little bit about older women specifically. We've already discussed what vaccines we would do for them, what tests we would do for them. If you've noticed, this age group, we've stopped doing pap smears. Mammograms are ending at 70. So some of those screening tests we're not doing, we're still doing some vaccinations. But I want to talk about some things that make these women different, basically, so that you kind of know some things to focus on in a visit. First of all, the psychological dimensions of aging kind of involves a series of natural occurring changes in the nervous system with some individual variation. I think we all know this to be true, right? We all know many examples of old age, from our current president, who is up there in age, who seems to be very functional, to those who are not living independently and might be in a care center. Genetics plays a role in the aging process, along with lifestyle and finally social factors, such as, I think, if you look at things, those who have more connections with society and have more, do things that kind of keep their brain going, go play bingo, go play Sudoku, are going to have some better cognitive retention. One thing I want you to notice is, have you ever seen someone with like a hard life and notice that they look older? Many losses paired with personal and financial losses will definitely age a person. One of the things I've noticed working in the ED is when I am working with someone whose life has been really rough, I can see it. When I'm working with someone who maybe was kicked out on the streets when they're 10, has been a prostitute for 20 years, I will look at them in my brain. I will think, oh, they must be 40 or 50. And I'll go in the room and look at their chart and realize that they are 28. So definitely a hard life ages somebody. In an annual visit for a patient in this age group, I'm going to also watch for, along with their cognitive function, polypharmacy. As people age, responses to therapeutic interventions are going to decrease, making them more susceptible to the toxic side effects of medications. I want you to think about the lock and key analogy with this one. There's receptor sites that are the locks, and medications are the key. And when the key goes into the lock, the medication is utilized. In old age, the receptor sites, such as the locks, are jammed and keys cannot enter. Because of this, there are more keys, and the side effects are those keys that are left over. You may also find medications compete for locks, such as a patient might be on 5 or more medications, and 5 medications is considered polypharmacy, that all need the same receptor sites. So a doctor might have dosed the medication thinking it's low, but the reality is since the medication is not being utilized and going into the cells, it is at a higher concentration in the plasma, resulting in some serious side effects. And then finally, let's talk a little bit about sexually transmitted infections. One of the most surprising things I had as a young clinician is working at Planned Parenthood caring for patients in this age group. One thing I found out is they are not as good, in my anecdotal experience, this is not bared out by research, but in my experience, they were not as good as their younger counterparts at using condoms. And part of this was due to the fact that they couldn't get pregnant. And so I would run into these older women and older men coming in with sexually transmitted infections who in their day had not learned a lot about sexually transmitted infections. They were newly widowed and they were having new partnerships. And this resulted in the need for sexual education for this age group. And it's interesting to me because I actually find the younger generation, the teenagers of today, are less risky in their sexual behavior. They wear condoms, and all in all, there's a lower teenage pregnancy. But on the other side, I see a higher rate of STIs in the 65 and older. A couple of things to talk about also is I want you to watch for loneliness or social isolation. Now remember, those are two different things. Social isolation is separation for loved ones. If you think about this, COVID has had a major play for this. There might be many people out there who are unable to be with their family or friends, and this can lead to increased rates of depression. When you think of loneliness, this is a state of mind. This might be somebody who feels lonely, although they are surrounded by some support or surrounded by a group home. So think about the old adage, water, water everywhere, and not a drop to drink. So when I'm talking to someone who's older and they're telling me they're lonely, but they're living in an assisted care center and their family's visiting, they might be depressed, and helping them this might be someone who might respond well to an antidepressant, but also might be somebody who might kind of respond well to cognitive therapy to help work out some of those emotions. And I do think in this age group, it is really important to address their emotional states and to make sure that they are, I guess I want to view things that I'm going to be happy till the end. I want to make sure that I'm continually growing in my life process, even as my abilities kind of decline and my mental cognitive functions decline and my physical body declines. I still want to be working towards happiness and having good interactions with others. And I think it's important that we recognize this need in our patients and view them in context of their social lives. Let's talk a little bit about Alzheimer's disease. About 2/3 of all cases in America are women. There's some belief that there's some sex specific due to hormonal changes. So if you think about the menopausal process, they think it could lead to this. So there are screening tools that you can use for Alzheimer's, and you can find them on the Alzheimer's Association's webs page. You can also find it on page 111 of your text. And then finally, we should talk about some physiological changes you will see in older women. When you're doing a vaginal exam, the vaginal rugae will kind of atrophy and you're not going to see it as well. The vagina, in a weird way, is a use it or lose it organ. When someone has not been sexually active, it tends to shorten up. The color of the actual introitus becomes like a pale pink, and this is kind of showing you a state where they're depleted of estrogen, and then even the structures can fuse. And understanding the physiological process of why they're fusing can help you understand the treatment. So when a patient has the labia minora and majora fused together, you're going to probably use an estrogen cream. It's due to not having enough estrogen from being in a postmenopausal state. And if you think about this, if somebody, I run into this actually quite a bit, if somebody hasn't been sexually active for years and they've now formed a new partnership and they're more socializing and they're returning to sexual activity, they might find this tissue is more frail and friable. And because it hasn't been used, it's atrophied, and they might find that it's painful to have sexual intercourse. So if you have a patient who presents to like this, talking about ways to help them feel more comfortable and make sex less painful is going to be very important. We will talk further on about helping women with painful intercourse. I have found with this generation, though, it becomes a little important to bring it up. For example, I had a patient who got married at age 68. She was religious and had never had intercourse, and was visiting me the first year after getting married. And bringing that up, I found really opened doors with this patient just asking her how things went in that department and what could help out, and her finding out that there is help to make, sexual intercourse comfortable and something that could be good for her. And, I don't know if that generation talked about these things so much with their doctor. So I think it's also nice as the provider to address these things in a sensitive manner. You read the room, right? If you bring it up and someone tightens up and you can tell they're uncomfortable, then back it off. But it also opens the doors and it sends the message that they can discuss uncomfortable things with you. And, that message needs to be sent in office. Okay, when you're using a speculum exam on these women, it is important, if you need to do a speculum exam, and the reasons you would need to are usually like post-coitus bleeding, because remember, bleeding after menopause is going to be endometrial cancer unless proven otherwise. And as the provider, you will always prove it otherwise. So if you're going to spec this patient, and it would most likely be for an endometrial biopsy, be cautious about the size of the speculum. Make sure that you are using the smallest size possible if there's somebody who has had a lot of atrophy of the vagina. Also, women face atrophic vaginitis. This is common 55 and older. It's basically the thinning of the vaginal epithelium due to the diminished estrogen. We talked about this before, but basically it's that dryness and the irritation. All right, and then last thing I want you to think about, now that we've moved from the physical exam of the patient, we've talked about the screenings we do, the vaccines, some of the social issues and cognitive functions. I want to bring it back to just looking at the patient overall. I want you to think about how frail she is. When women have gone through hospitalizations, they're going to be more frail. So finding out the patient, usually in an annual visit with a patient from this age group, I'm going to ask, have you been hospitalized this last year and how many times? If they're being hospitalized multiple times, they are more frail. Also, we should think about their cognitive impairment and think about this in multiple areas. How are their ADLs? Are they able to remember things? Are they able to function independently? Do they need support? If they need support, having that support person there and asking how much help they need. Do they need the same amount of help this year as they needed last year? Are things stable, or have their loved ones noticed a major decrease in function this last year? Let's talk about unintentional weight loss. With that, you can think of cancers. When you think about breast cancer, we quit screening for it at a certain point, but reality is once you get to be older, you're much more likely to have cancer somewhere in your body. It's almost like an 80% once you're 80 that you've got breast cancer. Discuss with women fecal and urinary incontinence, sleep disorders, fall risks, and then of course malnutrition. So this gives you a couple of the areas that you want to be focusing on with your older population. Also think about safety within their home. So if they are fall risk, they should not have rugs on the floor, making sure that they have guardrails up in their bathrooms to help them go up and down. If they asking them how many times, if they've had any falls, and assessing their risk in their home center. If you did have a patient that you had a lot of concern with, this would actually be someone you could assign for home health. And home health has the ability to go to a home and kind of address whether it is a safe place. And usually it doesn't mean the patient has to come out of their home, but they can give the family advice with ways to make the home safer to decrease risks of fall. All right, and finally, these are my references, and it is the same references as the apps we use because that is what we are using to decide. American College of Gynecologists, Centers for Disease Control, USPSTF, and ACCS are going to tell us our guidelines in women's health. Okay, thank you so much for your time.